The human skull acts as a high-density, unyielding vault, specifically evolved to shield delicate neural tissue from external physical trauma. This protective rigidity creates a lethal clinical constraint. The adult cranial vault has an expansion capacity of 0%. A space-occupying lesion, or SOL, introduces an alien volume into this fixed environment. These masses range from primary brain tumors and pooling hematomas to bacterial abscesses or parasitic cysts. Because the bone cannot expand outward, any new growth within this closed system occurs at the direct physical expense of the existing brain tissue. An undiagnosed SOL effectively turns the skull into a physiological pressure cooker, where rising internal tension crushes neural pathways and chokes off intracranial blood flow. Managing these lesions requires looking past the tumor itself and understanding the high-stakes fluid dynamics that govern the entire cranial cavity. The Monro-Kellie Doctrine is the governing law of neurophysiology, dictating the total volume inside the skull remains constant. In a healthy state, brain parenchyma occupies 80% of the space, while cerebrospinal fluid and blood each account for 10%. When a new mass, such as a meningioma, begins to expand within the parenchyma, it immediately challenges this equilibrium. The brain initially maintains normal pressure by physically squeezing venous blood out of the vault and displacing CSF into the spinal subarachnoid space. This displacement phase is why early-stage brain tumors are frequently clinically silent. The brain hides the growing mass by sacrificing its own fluid cushions. This spatial compliance has a hard limit. Once the reserve CSF and venous blood are depleted, the internal system cannot absorb additional volume. This chart shows the relationship between volume and pressure. Following the flat phase of condensation, even a 1 milliliter increase in mass triggers a sharp exponential spike in intracranial pressure. This pressure spike manifests clinically as a severe headache that worsens during coughing or physical straining. It is followed by sudden projectile vomiting. This symptom is unrelated to food intake and often provides the patient with brief, temporary relief from the pressure. The most critical objective sign is papilledema. Elevated pressure transmits directly along the optic nerve sheath, causing the optic disc to swell. If this pressure remains unrelieved, papilledema progresses to the full moon stage of optic atrophy, resulting in permanent blindness. Taken together, these symptoms indicate that the brain has reached the edge of its physical reserve and has completely run out of available space. Beyond generalized pressure, SOLs create focal deficits by directly crushing specific neuroanatomical structures. The skull is partitioned by the tentorium cerebelli, a rigid dural membrane that splits the interior into two distinct compartments. The supratentorial compartment, located above this membrane, houses the cerebral lobes. Lesions here often produce lateralizing signs, such as contralateral hemiparesis, or speech defects like dysphagia. If the mass compresses the optic radiations, it can cause homonymous hemianopia, a deficit where the patient loses vision in half of their visual field. The infratentorial compartment lies below the membrane and contains the cerebellum and the brainstem. Because this posterior fossa is much smaller, lesions cause intracranial pressure to rise far more rapidly. Classic cerebellar signs include ataxia, a stumbling gait, along with slurred speech, involuntary eye movements, and general incoordination. With a brainstem glioma, direct compression of cranial nerve nuclei causes severe deficits, like a squint, facial palsies, and nasal regurgitation of fluids. By mapping these peripheral deficits, a clinician can use the physical exam as a neuroanatomical GPS to deduce the exact coordinates of a tumor. If the pressure continues to rise, it leads to brain herniation, the lethal end stage where brain tissue is forced across rigid structural barriers into adjacent compartments. In uncal herniation, the medial temporal lobe is crushed through the tentorial notch, compressing the midbrain. In tonsillar herniation, the cerebellar tonsils are violently forced through the foramen magnum. This physically crushes the brainstem, causing immediate respiratory and cardiac arrest. This is the point of no return. This mechanism creates a fatal clinical trap. A patient presents with a severe headache and vomiting, which can easily be misdiagnosed as meningitis. The standard protocol for meningitis is a lumbar puncture to test the spinal fluid for infection. However, if an undiagnosed SOL is present, draining that fluid creates a sudden pressure vacuum directly below the brain. Performing a lumbar puncture under these conditions will instantly induce tonsillar herniation, killing the patient. Clearing a patient for an SOL is a mandatory prerequisite for any spinal tap. Because invasive tests like lumbar punctures are contraindicated, 90% of an SOL diagnosis relies on the clinical history and physical examination. Modern imaging has replaced obsolete high-risk methods like air encephalography, allowing doctors to safely bypass the skull's rigid barrier. Computed tomography, or CT, is the standard for acute settings. It rapidly identifies midline shifts, large masses, or active intracranial hemorrhages. Magnetic resonance imaging provides the superior soft tissue contrast required to characterize tumor types, define margins, and assess surrounding edema. These images do not replace clinical judgment. They verify the physiological and anatomical realities a doctor has already deduced from the patient's presentation. Immediate medical management focuses entirely on manipulating the Monro-Kellie variables to reduce intracranial pressure. Osmotic agents, such as intravenous mannitol, are used to physically draw fluid out of the brain tissue and into the bloodstream. Corticosteroids like dexamethasone are administered specifically to reduce the vasogenic edema that swells around brain tumors. While medicine buys critical time, definitive treatment requires surgical excision, neuroendoscopy, or targeted radiotherapy. Managing a space-occupying lesion is a high-stakes race against spatial compliance. Mastering the physical rules of the cranium is the only way to intervene before the brain reaches the point of no return.